Um, so assessment, we need to see if there's any symptoms that accompany that and what kind of signs we are going to look when we do our physical exam. So constipation may be associated with anorexia. Patients are not eating well. They can have nausea, vomiting. They can have abdominal pain. They feel full. They feel bloated. Some tenesmus, like an urgency to go. Nothing is coming. They may have diarrhea, as you know, and we'll see that in bowel obstruction. That sometimes it's a combination of diarrhea and constipation, and they can have some either blood, mucus coming also that may orient you to another cause of the constipation. Abdominal, they can have distension, palpitation, even some masses. If it goes that far that the patient is impacted, you will have masses in the left lower quadrant, most likely in the sigmoid. Isn't it? It becomes so hard, then finally it's there. Rectal, so when a patient is telling you that is constipated and did not go and have a bowel movement for 3-4 days, we need to do a rectal exam because you will find something. You will find if there's something or not. Are there stools over there? Is there nothing over there? Is there something, leakage? And so you need to look into that because that will give you also a clue of what kind of medication to use. Management, two types of management, general approach and then medication approach. So of course, if you can, which not often we can in advanced cancer, increase the fiber and the hydration, do it. If you cannot, of course, this is not good. Encourage activity, oftentimes you cannot do that. Treat medical factors, the one that you did identify. Create favorable environment. Anticipate constipation. We used to say when you put a patient on opioids, you have to prescribe some laxative as well, unless patient has a diarrhea problem for one reason or another. Otherwise, you have to, because what will happen is that in a week or two, patient will come to the emergency room with complaint of no bowel movement, abdominal pain, nausea, vomiting, and it will be impacted. So most of the patient will need some prophylactic laxative. We are going to come back which one are the best perhaps for the patient. Still in the general principle, you have to make sure that the patient, when a patient comes to you, and this is tricky, come to you, say no bowel movement for about 5 days, some nausea and some vomiting, be careful, he may be in bowel obstruction. And you don't want, if he's in bowel obstruction, you don't want to push all kind of laxative over there to increase the gut mobility because then it will increase pain. Therefore, you have to have an ID. And sometimes it takes an x-ray of the abdomen, a simple KUB, to see if the patient is impacted or if the patient is in bowel obstruction before throwing all kind of medication over there and create more harm than not. Know the mode of action of selective laxative. So a laxative is not a laxative, in the sense that there are many types. And then again, like the nausea and vomiting, you need to know what you need, what kind of laxative. We'll come back to that. Discuss the approach with the patient. Some patients will refuse entirely to have a suppository at any cost, even though this will be the best modality for that patient. For whatever reason it is, they cannot have so therefore you have to look for something. Some other cannot have an enema. They will just resist your enema. Therefore, again, you will have to be imaginative to find something else that may suit your patient. Adjust the dose to optimize the effect, switch or combine the agent. Most likely, it will be very rare that you will have only one agent that will do the whole trick. You will see and you will understand very easily because they all have their different mechanism of action, and therefore you oftentimes need to combine 2 or 3 mechanisms of action. These are the laxative. You have the drug on the side, the daily dose, and the action. So what you need to know, it's not necessarily the name of the agent, but the way the action is. And then depending on what you identify as the problem, therefore you will choose your drug accordingly. So you have what we call the contact cathartics. So these one will stimulate the gut. So if you have a lazy gut, a paralyzed gut, a patient who is on opioids, and we know already that it will slow down the gut, so therefore you need to stimulate the gut. Well, think about, there's about 3 of those agents, the Senocot, the Sena, the Bisacodyl, the Dulcolax, and the Cascara. And you have the doses over there, so these are the ones that will stimulate the gut. So if this is what you need, go for those. If you need something that will osmotic cathartic, so something that will water retain in the lumen and then will decrease the transit time, you talk about the lactulose, you talk about the mag phosphate and all those ones. Don't forget that if you use those, you should not be dehydrated. A patient who is dehydrated, because this will just keep the water in to mix things and soften the things. So therefore, if you are very dehydrated, this may cause problem because you don't have enough water to use. They have what they call wetting agents, softening agents. They are usually weak laxative, therefore they can be used all the time because their action is not really action that will stimulate or do harm to the gut. Therefore, they should probably be used all the time, and this is the DocuSat that you can use. Then you have the lubricants. The lubricants are something that will lubricate, as the name say, mineral oil. These ones are not all that great for long term. They will just coat your gut and sometimes even avoid that some nutrients will be absorbed by the gut. So this is very transient. A patient should not be on mineral oil. The other thing also with the mineral oil, it can give you some aspiration pneumonia. So this is not something that you use, it will be used for fecal impaction, but for short-term use. The bulk forming, so the bulk forming, you know, psyllium and those fiber cereals that you have, very good, but for people who are healthy, because you have to have enough water again. You have to be well hydrated to use the bulk. Otherwise, it will make a big bulk, and then it will stay there, and it won't move around. So usually, those agents are not for patients who have advanced disease. You have the lavage. The one that are osmotic, that will again water retention, and this is the polyethylene glycol. This is the Miralax. And those agents, again, if you don't have water, if you are very dehydrated, they may not be the best medication to use. There's the prokinetic agent. Cizeprid is no more on the market, so forget this one. So metoclopramide sometimes can help if you don't have. The only contraindication to use this one will be if you have a bowel obstruction. You don't want to stimulate a gut who is obstructed. You will just increase the pain. Opioid antagonists. So I remember Dr. Portnoy a few years ago gave a talk. I think it was in the MECU resident, and he said, well, oral naloxone. That was at the beginning of all those agents were starting. And said, here goes a resident who put his patient on oral naloxone, but the patient was not even on opioid. So again, oral naloxone, if you are not on opioid, you don't think about this one. Okay, don't throw an agent. It has to reverse the constipation due to opioid, but if you are not on opioid, forget about that. It's not an agent for you. So the oral naloxone was the first one on the market, and this is the one that you use to reverse any sedation, overdue sedation to the opioids. So it's a liquid form that you use. The dosing is about 4 to 18 milligrams. It reverses only the effect of the gut, although it may reverse slightly the pain as well, so you have to be a little bit cautious about that. There are better drugs on the market now, and this is the Relistor, the methyl naltrexone, which is probably has a better profile. Do not reverse does not cross the brain barrier, therefore has a better profile, and so can be used also, which is shown to reverse, I think, constipation about 50% of the cases. So one dose and you go. So that's good. The cost is, again, a problem because it costs about $40 per shot. Therefore, that's not for everyday use unless you have some money put aside. I'm not sure the reimbursement by the healthcare system Is it well reimbursed, or you have to demonstrate, I suppose, that you cannot use something else? So again, this is a third line. It's not a first line. It's never a first line for our patient. You have all the rectal agents, and then again, they can be used. Keep in mind that if a patient who had no stools for about 4 or 5 days, just putting something through the mouth, oral, will not probably be enough to do any good. So you will need something suppository or enema to help also for the lower part of the gut. So glycerin laxative containing a stimulant, you have the Dulcolax, can be good. There is what they call the bomb or the double Duke, which is 2 Dulcolax suppository, and usually work better. Keep in mind that the suppository, if there's no stool in the rectal ampulla, probably will not do much. Will just do a little bit of, sort of oiling the rectal, but will not provide much. It has to be in contact with stool. So sometimes you need enema, small, large. There's all kind of enemas on the that you can use.
Just before we get off constipation very quickly, this is really a symptom that we don't talk a lot about, the psychological aspects to this symptom, but it's really important to keep that in the back of your mind in terms of dignity, control, and many, many other psychological issues attached to this, because privacy, allowing people, having these discussions in private, not with a group of 5 and 6 people talking about bowel habits. So we don't talk a lot about that, but we really need to pay attention to that.
Yes.
It's a profound symptom.
Yeah,
really
absolutely. Yeah. And it creates a lot of discomfort in our patient as well. So all the GI tract.